Thanks. All right. Welcome, everybody. This is the monthly Oregon Cost Growth Target Technical Advisory Group meeting. Oh, sorry, little technical difficulty. All right, let's get started. Next slide. Okay, so here's the agenda for today. We will run through program updates per usual. Attached to this meeting are the draft 2023 data submission materials. As we sort of spoke about last time, the only documents to get updated this year are the specifications manual and the submission facts document. No substantial changes in reporting methodology. All of our changes were to clarify and tweak some questions people had about submission. So those are the only two documents. The template itself is not updated, but we do have a discussion section in today's tag meeting that may or may not change that. Not to freak people out, we're only talking about an optional field. But yes, stay tuned for that conversation pertaining to medical pharmacy spending. And that's all we have today. Next slide, please. Okay, so in our March tag meeting, the notes have been uploaded to our tag website. We continued talking about entity level public reporting. This is happening with a report coming out later in May. We've been slowly ramping up transparency. Part of transparency is public reporting at the entity level. So that is coming up very soon in a couple weeks. We spoke in the last 2 monthly tag meetings with folks about how we should visualize entity level trends. We walked through what other states did. We did some mock-ups with Oregon entities, payers, and provider organizations to see what that might look like. And thanks to a lot of engagement and discussion and pros and cons of a whole number of variables, we were really happy we came to a lot of data viz decisions and how to report by markets. So last month we spoke about stratifying, especially for provider organizations, because we do have a fair number of them. We talked about stratifying provider organizations, particularly health systems and large practices by member month size. So you'll see some of those groupings in the program update. And also started broadcasting to each organization an email displaying their 2020 to 2021 trend, as well as the range for their particular group. Also, what happened was we previewed the manual and data submission facts. Nothing has changed. There was a mistake I caught in the manual last month that we've corrected, so I'll be really sure to point that out. And for sure, in the final version released in May, that will be corrected. And we also mentioned, yes, 2023 data reporters will be notified by April 30th. So that happened, I think last week or early this week. All data reporters that we are anticipating a file from this September have been notified. No big changes to our list from last year. Yeah, and that's that. Next slide. All right. not going to go through this slide too much, but this is a further breakdown on some more granular points of conversation we had at the last TAG meeting, how to stratify provider organizations. We did decide on member months. We spoke about geographic considerations and also differentiating payers based on whether they were foreign and domestic. And ultimately, we decided not to go with either of those. We want to balance the reporting and make it easy to, well, relatively as easy to ingest as possible, and not include a lot of noise that wouldn't be valuable for the audience. And we mentioned another consideration in the report, which is to display somehow and recognize commercial partial claims. So this is just for the commercial market. Do you want to add anything, Sarah, before we move forward? Okay. Let's go ahead to the next slide. All right. We have a couple program updates for you, and for this, I'm going to hand it off to another cost growth target analyst, Margaret, which some of you know from our data meetings we've had in the past year. Margaret, take it away.
Thanks, Trang. Hi, everyone. So yeah, I'm going to go over some program updates. I think we can go to the next slide. So the first program update is just a reminder about the 2023 public hearing. I think, as we mentioned at the TAG last time, the advisory committee decided to break up the public hearing on the 2020 to 2021 data into 2 iterations. So the first hearing is coming up soon on May 17th, save the date, and that'll be focused on presenting the cost trends from 2020 to 2021. And then we now have a date for the second part of the public hearing, which is September 14th, a few months later. And that'll be looking at perspectives on 2020 to 2021 cost growth trends. So yeah, look out for further updates and check out the website for information on how to connect to those. Next slide, please. So yeah, the next update is focused on public reporting. As Trang just mentioned, at our TAG last month, we decided to break up reporting on provider organizations into different size groups broken up by member months. So we went back and looked at the distribution of provider organizations in terms of the member months in each market, and came up with a number of different group thresholds by size. So this is just looking at the commercial market specifically and which provider organizations ended up within which size group, and then the thresholds are stated there as well. We ended up with 3 groups instead of 2 just because of the number of provider organizations that we had in the commercial market. And then for commercial market, we're also going to break out pediatric organizations. Next slide, please. For Medicaid, we ended up with the same thresholds by member months, and we have the 3 groups and who fell into each group there. And then in addition, we're going to report on FQHCs together and pediatric organizations. Next slide, please. Unless there's, yeah, okay, cool. Yeah, and then Medicare Advantage market, just because there's a smaller number of provider organizations, we decided not to break that up by size, so everyone will be reported on together. Next slide, please.
Margaret, sorry, before we move on, can we pause for any questions about the reports or the public hearings? I know that we also sent out a Gov delivery yesterday with information about the actual release dates for the reports and the timing for the public hearing. So I wanted to just pause and see if anyone had any questions about what's coming up.
Sounds good.
I'm not seeing anything in the chat or any hands. Anyone coming off of mute? I assume that means we have over communicated with you all and you feel very prepared for this. I think, and just as a reminder, we did reach out individually to organizations to share where you were within that group range. So you also received that summary data point, but please feel free to reach out to us, any one of us on the team, or to our inbox if you have questions. And again, the identified payer and provider level report with the 2020-21 data will be published on May 9th.
Cool. Okay, yeah, so the last program update is just another 2023 legislative session update. And as a reminder, we're just providing this update as for informational purposes. OHA doesn't have a position on any of these bills, and we're not asking the TAG to take a position on any of these bills. So yeah, I think when we gave this update last month, there were 3 bills that were pending. That has been whittled down to 1, House Bill 2045, which is sort of an updated version of 2742. And so this bill would exclude workforce costs from consideration as total healthcare expenditures for the purposes of the CGT program. So basically exempting workforce costs from any accountability for cost growth. I don't know if there's any questions on that.
There's also a slight update since we put the slides together. So 2045-1 amendment is out. It's been posted and there is a hearing at the Rules Committee tomorrow.
Cool. So I think that's it for program updates, and we can go to the next slide.
All right, okay, thanks. So I'm going to run down once more the clarifications we did for the manual and the facts document, give some time for any feedback now that people have had a little over a month to look at those draft materials. Yeah. And take it from there. As a reminder, we are planning on finalizing the versions and posting it online by May 10th. All right, next slide. So as if you are a data submitter, you probably know by now we give a lot of data submission resources. The 3 big ones being, well, first the template itself, data specifications manual, and a submission facts document. We also provide a number of supplemental resources. 3 of them are outlined below. Only 2 documents were revised this year, the manual and the facts. And I'm going to run through those updates once more, a little more detail. Next slide. All right, so here's the mistake I did a month ago. So yes, we do have a new provider taxonomy code that's included in Appendix B. This is to assist payer staff in their attribution methodology, particularly if you're using Tier 3 and you're using those provider taxonomy codes. There's a new type of physician classification, and we had the wrong taxonomy code in the draft manual attached to the March TAG meeting. The draft manual attached to this April TAG meeting has the correct code, as will the final manual when we publish it sometime in the coming weeks. And you'll see that code here. It starts with 202D. Any questions about using this code? It did pop up effective starting April 2022. So you could possibly see it in your claims data if anybody is using it. Any questions? All right, let's go to the next slide. The next slide has a list of clarifications as well as the page numbers you could find it on. The draft manual we've attached to this tag meeting. You'll see the track changes in red. So I know it's like an 70 or 80 page document, but hopefully with the visual cues and these page numbers, you can track down these revisions fairly quickly. The first clarification we made was to kind of hammer out a little more explicitly the weighted average calculation for a certain data field in the TME All tab, and you'll see that on page 20. In a couple other places, no change to submission methodology or anything, but clarifying in a couple more places in the manual that when you are reporting the allowed amounts for medical expenses, we are looking for the full amount, no truncation for the state of Oregon at all. I know this is a little different from other states, so yes, no truncation in Oregon. The next clarification is relating to Medicare and Medicaid dual eligible expenses. This is something we worked on and did last year. There's no change this year, but we want to be more clear in, once again, like the clarification above, in multiple places in the manual, that whenever you are reporting for dual eligible expenses in line of business 5 or 6, we are looking for spending on a paid amount basis. And it doesn't matter whether you, the payer, are the primary or secondary payer for these members. I'm not going to get into it, but that's due to a quirk we discovered with how Oregon allocates spending for dual eligible expenses. Simply reporting the allowed amount doesn't give us the full spending. So we are reporting these 2 lines of business, spending in these 2 lines of business on a paid amount basis. And that's no change from what we did last year, but just clarifying it in the manual a bit more. The next clarification is which lines of business are accountable markets. So when you give us data, you are reporting spending in 6 lines of business. We collect a lot of data for statewide spending, market spending, as much as we can. But as for accountability for entities, payers, and provider organizations, not all 6 of those markets are going to be contributing to an entity's trend. So clarification on that is on page 11. Another clarification we are adding is for Medicaid CCOs, as a reminder to include expenditures for Healthier Oregon members. This program started, I believe, July 2022. So just that should be included in, there's a table in the manual on this page that is specifically what to include for Medicaid CCOs and what to exclude. So we added Healthier Oregon members in the inclusion category. Any questions before we move on? Those are all the big changes to the manual. All right, next slide. Okay, so the facts document. Some of these are the same content as the manual. For instance, the weighted average calculation we added as a new question, so people can see that. Same thing with the the accountable markets and how it aligns with the lines of business payers report in the template. Another repeated question is the last one, question number 14. This is for Medicare and Medicaid dual expenses. We're collecting money on a paid amount basis. So also if you're, when you're submitting member months in those, excuse me, in those categories, yes, that person will be counted twice, and that is okay. And then another new question, question 21, is on how to apply sex demographic factors if you have a member that's not listed as male or female. Right now, we are instructing people to use the male demographic factors. Any questions? Oh, and I think I could add, Sam could add something too, but folks that were not either male or female were included in the male factor formula when we made these tables. So. All right. If you have any questions about these updates, these clarifications, please feel free to shoot us an email and we will get back to you. All right, next slide. Okay, I think I mentioned this a little bit earlier. Looking forward to the September file submission, all mandatory data reporters have been notified of their status. If other folks on the line are curious to see the list is posted on our webpage. So you could see who we're talking to in Oregon when we're talking about cost growth target data and where it comes from. Next slide. Another little update, no substantial change to the list at all. We did have 2 carriers drop from the list to, so they're both United entities. And then we added 2 entities to the list, which are also United entities. This is looking like it's a little bit of a shift in the Medicare Advantage enrollment. So we're still talking to the same people, 38 carriers and actually 19 parent entities. We also have a list of voluntary reporters. You can see down here, 3 of them have dropped from the list and 2 were added to the list. I should also mention the threshold for reporting data to the cost growth target program is at least 1,000 Oregon lives across all lines of business. And we get that data from quarterly health enrollment data files from the Department of Consumer and Business Services. Next slide, please. Oh, and you can see the full list here. So this is just the list of mandatory reporters and their associated parent entities. Next slide. All right, so we are going to finalize the manual and template and fax document. We are planning on uploading these documents to our webpage by May 10th, so in a couple weeks. We haven't heard any feedback via email or this tag group. So, and because our changes are like mostly clarifications, taking that as a good sign, people are comfortable with the edits this year. So yeah, watch out for that posting. We'll be sure to not only send a blast out to our Gov delivery, which we're going to use more often, but we'll specifically reach out to all of our technical payer contacts who we know are compiling this data to make sure they see these 2023 versions of the documents. Any questions? All right, thanks for listening. I think we could go to our last, I think this is our last topic on the agenda today. All right, and it's a little bit different. So of course, right after I go through our, not substantial changes, we have this section on the TAG agenda about possibly breaking out medical pharmacy spending. We do want to put this in front of people today and see if, I don't know, just take a pulse check and see what everybody's thoughts were on this, and if this could possibly be something optional some payers might be eager to try out this September. So this is about trying to break out medical pharmacy spending, provider administered drugs in our cost growth target data file. Next slide, please. All right. So giving a little bit of background, drug spending, as we know and as we've seen in some of our data meetings, is a pretty big chunk of claims spending. Right now in the cost growth target template, there are 2 places where drug spending can be included. And it really depends on whether the spending was provided under the medical benefit or under the pharmacy claims, the prescription drug benefit. So if drug spending is under the medical benefit, we instruct payer staff to include it to according to the location in which it was delivered. So, if this was drugs delivered in a hospital inpatient setting, you put that in the claims hospital inpatient claims category. We have a separate category called retail spending, and that captures drug spending under a patient's drug benefit. So they're going to the pharmacy and picking something up. So that is retail pharmacy spending. Next slide. So it's important to know when we talk about pharmacy spending trends using cost growth target data, we are only looking at retail pharmacy spending. We don't see any provider administered drugs or any of those costs, which is kind of a blind spot in how cost growth target programs capture drug spending. So we want to talk to folks a little bit about that today to see if we might be able to try something this year. Next slide. So we are asking everybody, payers on the call, if there's a way we can see drug spending from the medical benefit, physician administered drug or provider administered drugs. This could be just using J codes from medical claims to identify drug spending, including included in other claims categories. So here is showing the, what is this? We have 9 claims categories. Retail pharmacy is one of them, but as you can see, we have 2 hospital categories, 4 professional categories, and then long-term care and other, which does include, other includes a lot of things, DME, but also hospice. Yeah, so this is just an overview of all the other places, you know, drug spending could be hiding under. So still contributing to overall total medical expenses, but not exactly in a way where we could, you know, distinctly see those drug costs. Next slide. So we're looking for feedback, just pulse check. If so, this is one option we thought of, adding an optional category in the claims section. So now instead of 9 fields, there are 10 claims fields. And that data field would be called claims medical pharmacy. So if we thought about drug spending in our example, hospital inpatient. So if you look at that little schematic down there, you would have, you know, that aggregate spend for that person, and that little blue dollar sign is supposed to represent spending on, it's supposed to represent drug spending. So you would still report all of those costs in this hospital inpatient category. But if you were able to pull out using J codes or a methodology, pull out that medical drug spending and insert it into this new blue data field, so we could capture medical drug spending. We wanted to, as the experts and the ones submitting data to us, we wanted to run this by you and see what you all thought about it. Are there pros and cons of this that we haven't thought of? And then lastly, if there are, and we realize you might have to take this back to your team to discuss, but wanted to poke around and ask if there were some payers that would like to test out this new optional field this September. So I'll mute myself and let people talk. I think there's some comments in the chat I'll take a peek at.
Can I add one note? And sorry, Trang, I was briefly distracted. So if you cover this, but I think part of the question here is it something that could potentially be carved out exclusively, mutually exclusively reported on? And I think, you know, Ada's comment in the chat is maybe hinting at difficulties with that. Or is this something that could be done in addition? So it's a bonus categorization rather than a mutually exclusive categorization. So we know there's a lot of work here where you could say all J codes are physician administered drugs, and here's all the spending for J codes. So I don't know if that makes a difference in thinking about feasibility, if it's mutually exclusive versus sort of add-on.
It looks like Bill has his hand up.
Yeah, I would just say that whatever, if this is a direction that you want to go, that's going to get complicated because of the fact that some drugs can be bundled into other services. For example, they could be delivered in an inpatient setting. There are certainly lots of drugs that are billed with a procedure code that does not start with a J. And so, you know, J code just, you know, I mean, yeah, I get what you're saying. A lot of them start with a J, but a lot of them don't. There are also drugs that are billed with a revenue code indicating pharmacy that don't have a procedure code on them at all. And so if you wanted to try to capture all of them, you're going to have to define a specific methodology based on revenue code and procedure code, along with a methodology for breaking out drugs that might be bundled into, say, a DRG payment, which is going to require prorating the DRG reimbursement, perhaps based on a percentage of the billed amount or something like that. So in other words, it's going to be complicated.
That is a great point about the DRG bundling. Thank you for that.
Yeah, and so, I mean, it's technically possible to come up with something, but you know, unless you plan to roll out a detailed specifications for all of the other fields, like for example, what revenue codes are you or bill type codes are you going to use to define inpatient and outpatient?
Yeah.
It wouldn't make sense to have this super complex methodology just for drugs while leaving it up to the discretion of the payers on how they're doing all of the other categories.
I think that's a fair point, and I would like to make two counterpoints. One is that we know that pharmacy is a major driver of spending in Oregon, and I think there is potentially some justification of spending extra time or having more detailed methodology to dig under the hood a little bit to understand what exactly is going on, because it is such a driver. So I think there's an argument that we could make there.
Yeah.
Two, I think there's I'm curious in your all's feedback about from sort of a is the juice worth the squeeze kind of conversation. So yes, we would be happy to write detailed specifications and methodology for this. Whether or not we capture all medical pharmacy, or maybe, you know, we get 80% of it, is that worth it? Is it helpful to have that? I mean, and we could do some work and some testing to say, all right, if we look at J codes, we think we're getting this much of it. If we based on place of service or, you know, other revenue codes, we get this much of it. It's maybe not exhaustive, but is that helpful to have that additional granularity and understanding where costs are and what's driving costs where? And if you all say, no, this is not worth it, retail pharmacy is nice and clean cut, and really this is just not worth the effort, even if we could capture part of it pretty easily. I think that's the kind of feedback we're looking for today.
I feel like we could do some exploration of our data and see if the juice is worth the squeeze. Like if we wanted to look at total net paid, and then of that total net paid in a given time period, how much of that went to J codes or rev codes that we knew, when it's not the whole kit and caboodle, but it's a 80% chunk. If that percentage of total net seems to be something worth tracking, I think then it just becomes, it does become a challenge because of the methodology for all these other categories. It's currently inclusive. So is it really that we're, and I don't know how everybody else figured out their methodology for categorizing things. You know what I mean? Like who decided what hospital inpatient was for them? I think we have all ideas of standards, but that wasn't in the specification guide explicitly. So unless we kind of want to come back as a group and find a definitive definition for each of these categories provided to everyone to make sure that we're all on the same page, I think getting down that line would be a great approach, but I feel like that would be year after next cost growth target reporting to have the time to flesh it out. But I'm happy to have us all on the same page. If we break out pharmacy with a certain specification, then we've all got it and we've discussed it together of the feasibility.
And let me clarify, I think we're not thinking about making a major change like this for this year's data submission. I think what we're asking today is, what do you think? Is this something we should start exploring and developing? And the soonest we might make wholesale changes would be for the 2024 data submission. Ada, thank you. I really appreciate that feedback. Do others have, other data submitters have thoughts about this? I want to make sure we're hearing different perspectives, or if you agree with Ada and Belle's points, please let us know in the chat.
You know, I have one more thought about that, and that is because there would probably have to be some complexity in this, then it seems to me, I personally would prefer you guys to be able to say, here is the methodology, because the time that is going to take for all of us to sit there and try to come up with a methodology on our own, you're taking it's like 20 times as much time and effort, rather than just somebody to say, here is the methodology we would like you to follow.
Totally fair. Oh, we've got a hand up. Go ahead.
I just wanted to propose that we might look at this as an opportunity for a volunteer or several volunteers to explore this and do a pilot program to figure out which mechanisms are best to be able to identify them, so that they could do it as on an optional basis this year, provide those standards to the rest of us going into the next year when we might actually implement them on a broader scale.
Yeah, thank you for that, because I think that was going to be the last prompt that Trang and I wanted to ask you. And I think it is very fair and reasonable for all of you to say you should come up with a methodology. If you want us to do this extra work, do some work. Do the work to test it. So if any of you are interested, if this is something any of you teams have poked at internally, you have interest and want to, volunteer to maybe poke around or test some of this with us, we would love that. I think we need to talk a little bit more about like timing and when that happens, and is this after the 23 data submission, and how long it takes to pull this all together, and be really sensitive that this is an add-on ask. But we absolutely would want to pilot this with a few of you. So I think if anyone is interested, let us know. And also, if you want nothing to do with this, that's fair too. Thanks, Ada. Any others? I mean, have any of you done any looking at medical versus retail pharmacy internally related to cost growth or not?
Yeah, sure. I mean, the medical pharmacy is huge. I mean, it's similar in order of magnitude to the retail pharmacy.
Mm-hmm. Okay, Trang, I didn't mean to take over, but I think I'll hand it back to you, but I think I definitely would encourage people, if you have additional thoughts or really strong feelings about this one way or the other, send us an email.
Yeah, thanks. This was great. All right. So with that, I think that brings us to our wrap up. All right, so if your brain was tickled by that conversation we just had, send us an email, and we'll maybe explore this with a group of available intrepid payer staff. All right, so that's the end of this meeting. We are ending a little early today, so giving everybody a little over an hour back of their day. The next TAG meeting is May 24th. I'm not sure if we'll keep it if we have content, but on the agenda for that TAG meeting are any changes to the draft in the release data template in manual. I know I've said this multiple times, but look out for the updated 2023 versions of the manual and facts. No update to the template, but you will get a 2023 version in the coming weeks. And with that, thanks for sharing some of your Wednesday with us. Have a great rest of your morning.
Thank you.
Thanks, bye.